warahmatullahi.
First of all, I would like to welcome you to this pre-conference event of the first International Conference on Data Science and Official Statistics, ICDSOS. This seminar is organized by Polytechnic Statistika STIS, BPS Statistik Indonesia, in collaboration with Forum Pendidikan Tinggi Statistik Forstat and Ikatan Statistik Indonesia ISI, and will be held on November 13 and 14, 2021. My name is Nuka Widowati Kusumoprojo, a lecturer from Polytechnic Statistika STIS, and I am serving as moderator for this pre-conference. Before we continue, I would like to ask the audience to turn your video on if possible, and keep the microphone mute at all times, except if you want to ask questions during the discussion session directly. In this pre-conference event, we shall have an outstanding presentation from our prominent speaker, whom I believe shall enrich our insight and knowledge regarding the theme of the ICDSOS, strengthening the contribution of data science and official statistics to the society in the disruption era. To get a complete picture of the first international conference on data science and official statistics, let's check out this video teaser.
In the middle of dynamic world development, it can't be denied that data has important and vital roles. Various fields of life, such as economy, health, education, and others, need data as a basis for planning and policy making. However, in reality, data incompatibility between one agency to another is still being often faced with a problem. Therefore, validated data is needed. Official statistics produced, collated, and disseminated by National Statistical Office are almost nationally representative because they are obtained from complete censuses or large-scale national sample surveys. On the other hand, the modernity of technology supports the production and dissemination of data that can be done very easily, anywhere, anytime, and by anyone. Big data, a data source besides census and survey, also have an important role at this time. By combining survey data with available administrative data in big data, NSO can save the cost of data collection and processing and reduce the respondent's burden. The new idea of using multi-source statistics bring new problems. One of them is the complexity in multi-source statistics production, which is combined from various high variation sources. Although various research has been done continuously, there is no indication which method could be applied in a particular situation arising in practice. The increment of volume and variations in data types and sources increase computing power and improve data science methods to change society in fundamental ways. What is the role of data science and official statistics in this disruption era and its relation to developing new statistics and using modern data sources?
Thank you, host, for the video. Well, interesting, isn't it? The ICDSOS submission date is already open until 31st August 2021. And the conference cover fast topics that can be seen at the conference website, icdsos.stis.ac.id. On the website, you can register as presenting participant by submitting a paper or a non-presenting participant. All right, let's continue. At this time, I would like to invite Ibu Dr. Erni Triastuti Ahmad, the Director of Polytechnic Statistika STIS, to give opening remarks for this pre-conference event on behalf of Civitas Academica Polytechnic Statistika STIS. Ladies and gentlemen, please welcome Bu Dr. Erni Triastuti. And Bu Erni, the time is yours.
Thank you, Bu Nuke. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, and good morning to Professor Barros. Your Excellency, Professor Pedro Pita Barros, distinguished guests, participant, lecturer, student, ladies and gentlemen, I hope you all going well today. It is a pleasure to welcome everyone here, and thank you all for attending the pre-conference of the first international conference on data science and official statistics, which is organized by Polytechnic Statistika STIS and BPS Statistics Indonesia. First and foremost, I would like to thank and give my appreciation to Professor Pedro Pita Barros that be able to be here with us today and sharing his knowledge to us. And for all the participants, I also appreciate all for making the time to be here. Before this pre-conference begin, please allow me to briefly introduce our campus, Polytechnic Statistika STIS. It is a national statistical institute under the supervision of Indonesian National Statistical Office, BPS Statistics Indonesia. We have a vision to be a high-quality campus and excellence in applied and computational statistics, and commit to give a real contribution to national and international statistical system. Therefore, we are aspiring to have a professional, integrity, and trustworthy students here. This program we have here is an undergraduate vocational program in statistics and computational statistics. For the past 30 years, we have seen an increasing volume and variety of the data. Combine it with the advancement of the technology with improvement in big data and data science, our field has an important role in the fundamental ways in society. Furthermore, we need to promote the value of data science and official statistics. Therefore, the pre-conference held today is about the establishment of the main event, the ICDSOS, which will occur on the 13th and 14th of November later this year. The first conference of ICDSOS will be about strengthening the contribution of data science and official statistics to the society in the disruption era. The main topic of the upcoming conference is to discuss the development of data science, applied statistics, and also official statistics.
I'm sorry, Bu Erni. Could you please turn on the video? Thank you.
Sorry. Okay, and lastly, I would like to encourage the student and all the participants here to ask and discuss more about the topic that Professor Barros will explain later. Thank you all and hope you all will be enjoying this event. Thank you. Back to you, Nuke.
Thank you, Ibu Erni, for bringing greetings to this pre-conference event. Thank you very much. Moving right along, we will start our main event. It is now my pleasure to introduce our invited speaker. Please, host, share screen for the CV. Professor Pedro Pita-Barros holds the BPI Fundación La Caixa Chair in Health Economics. He is a professor of health economics at Nova School of Business of Economics, Universidad Nova de Lisboa. He is a member of the European Commission Expert Panel on Effective Ways of Investing in Health, a member of the Portuguese National Council of Ethics for the Life Science, a member of Portuguese National Health Council, past president of the Portuguese Association of Economics, and past president of the European Association of Health Economics. He served as a member of the board of the Portuguese Energy Regulator, member of the Governmental Commission for the Financial Sustainability of the Service, and on the European Commission Mission Board for Cancer. Professor Pedro served as Vice Rector of Universidad Nova de Lisboa in the 2013 until 2017. He serves on the editorial boards of academic journals in the field of health economics. He is a consultant for both private and public entities in Portugal and the European level in the area of health economics, competition policy, and economic regulation. Professor Pedro Pita-Barros received honors of Grande Oficial da Ordem do Infante Henrique, awarded by the President of the Portuguese Republic in 2005. He received a gold medal of the Ministry of Health of Portugal in 2012. And not only receiving honors, he also has an award, the Pedro Pita-Barros Award, created by the Portuguese Association of Health Economics in 2018 as recognition of the development of health economics in Portugal. His research focused on health economics, regulation, and competition policy, and already published in many academic journals. He also has several books on health economics, both in Portuguese and English. For the complete publication list and some other information are available at Google Scholar, ORCID research profile at Universidad Nova de Lisboa for the list of publication, Scientia Vitae or CV application by the government. This outstanding achievement from our invited speakers. It should inspire us no matter what fields we are in. In this pre-conference event, Professor Barros will deliver a presentation entitled Share Decision Making in the Portuguese National Health System, Choosing Wisely, in around 45 minutes. The audience may use the Zoom chat box to write their question during the presentation, to write your name. And I will also give opportunities for some of to ask question in the discussion session later directly. So you can raise hand using the raise hand feature in the Zoom. So ladies and gentlemen, please join me in welcoming Professor Pedro Pita-Barros. Professor, the time is yours.
Good afternoon. Thanks, Nook, for your kind introduction. And thanks, Dr. Ernie Triastuti, for your kind invitation and for having me this morning. I hope that you do not regret at the end that you invited me. I'll try to make this presentation as interesting as possible from my side, from people from statistics, although I'm coming from the health economics. I've been mostly of my time being a user of statistics, so thank you all for being on the other side of producing the data that we all need as decision makers, as researchers, as academics on this. On the questions, please feel free to ask whatever question you want, even if it is not directly related to what I'm presenting. I'll be glad to try to answer the relationship with what I'm doing. And during the presentation, I also try to highlight where the role of the statistical office is important in what I'm doing here, and what are the possible developments that will be interesting to have in several dimensions. I'm not going to move then to the presentation. And I'll try to be on the 45 minutes mark. And Nook, please, when 5 minutes are remaining, remember me that I'm getting over time.
Sure, sir.
Okay, so I choose to present this work for a couple of reasons. One, it's still ongoing work, so I can benefit from your insights also on how to improve it, but also because it shows a bit how do I see the use of data, and how do I see the best way to mix the data with the need for understanding policy, and how to combine that with some elements of conceptual frameworks. And so I'm going to, during today, I'm going to first describe briefly a patient choice initiative that took place in the Portuguese health system in 2016, and try to explain what was the change and what is the demands that the change implies. And I will then move to a quick overview of what are the conceptual framework that we should adopt to understand what's going on, and what are the demands on data and the demands on use of data that conceptual framework brings. And so the interpretation of data needs to have some background in terms of ideas. How should we interpret the observed data, and then how we should organize the data to understand better. Then I will move to the data that is available at the current times for addressing this problem. And I think that we can discuss what will be the alternatives to have other data and what level we should have it. I will show some preliminary results. Still pretty much ongoing work, and there are some issues, technical issues as well, that I would like to share with you. And then I'll talk about next steps, what will be ideally to do. And so I hope to give you a glimpse of what I'm doing, and also benefit from your insights to make it this better work in the future. So let me start with a problem. And when we talk about data, and since we are in a data science conference, and I thought it will be interesting to frame the several aspects and try to link to data as much as possible. So this was a good example of that, because it was a change in the way that hospitals and primary care and patient choice works in Portugal. There was a normative action, as usual, in when we have decision makers taking decisions. I guess that will be the same almost everywhere. At some point of time, you have some decision makers and lawmaker setting up a rule, government official setting up a rule that it puts into law. In this case, was the name of the law is that despacho. I'm not going to go into the legal aspects of what that means, but it's just a law that says that how decisions should be taken by hospitals, patients, and general practitioners in primary health care. And so what is the system that we started with? In Portugal, for a long time, we had a situation where people are covered by the National Health Service, and they are attached geographically to a certain area and to certain providers in that area. And so we have the general practitioner, GP, that oversees the health of people, and we should have a GP that is guiding us into the health system. And at some point, if we need to go to a hospital, say to have a cardiology consultation with a specialist, or we need to have some other specialty consultation, the GP will send us to the hospital of the neighboring area, of the catchment area. And so there was a strict rulings on where we could go if we needed a cardiology consultation. Now, what happens in 2016 is that the rule changed and said that the patient, jointly with the GP, with general practitioner, with the family doctor, will decide which National Health Service hospital anywhere in the country could be having this cardiology consultation or any other specialty. So if I want to get an appointment, if I as a patient want to have an appointment with a specialist in a hospital, I can decide with my GP which hospital I would contact. And this is replacing the previously catchment areas defined by geography. Now, the important part of this is that you have now choices for the patient, but you need to have some information to the patient. And that information needs to be collected and needs to be made available. The law itself makes a reference to what are the expected elements of the choice. And the expected elements of the choice that we think is geographic proximity. So the patient would like not to travel too much, but also information on the average waiting times per specialty in each hospital of the country. And here is where we start having the link to the data part. It starts to require that the National Health Service, as a body that provides healthcare, needs to have data on average waiting times per specialty by hospital available to the patients, so that they can see and they can decide where to go. And of course, this now is requiring that the system itself, that the National Health Service, is ready to provide that sort of data. And this means that you need to have ways to collect information for each patient that goes to each hospital and how much the patient waited, aggregate to the hospital level, and aggregate it in a way that patients can see that information when taking a decision jointly with the GP. And so this is the first demand on data, and it needs to make use of flows of data. It's not just a matter of having the data collected, it's also a matter of making the data available in a format that people can see. And that's also a kind of a challenge in many situations of using data nowadays, that sometimes I believe it's kind of overlooked. And that's, I think it's an interesting topic for our discussion in this conference. That is, one thing is collecting the data, another thing is collecting the data for official purposes. A different thing is still to collect data to make it available for individual decision makers, so individual persons being able to use it, how they are going to access and have that information. Now, moving on this, I have here just to show that I've done some homework of understanding what is the law. And on the right side of the screen, you have your first lecture on Portuguese. So you can't just ignore the right-hand side, just to show that it's credible what I'm going to say. And the official ruling of the Ministry of Health says that this is going to be applicable to the first specialty appointment in hospital. That's the first paragraph. And then you have the role of waiting times and geographic proximity, which is number 2 that you see there.
Yes, oh,
and then you have also information on waiting time for surgical intervention when surgery is relevant. So we have different types of data that needs to be provided to the patient. Is this information available? Well, actually, yes and no. And here again, it's the Portuguese screens, and these were taken a couple of days ago from the website of the Ministry of Health. Okay. I'm sure that most of you could not understand what's going on here. So the point, so I decided to use the cardiology example. Okay, so I decided to use the cardiology example. So this is about 2 hospitals. You have one hospital on the right, one hospital on the left, and it is an information that the patient can see when he logs into the website of the ministry. And it's going to give you some information, and it's information that was kind of referred to in the law. So I will have the waiting times available, which are the green circles that you see there, and they have on one hospital on the right-hand side and one hospital on the left-hand side, and it tells you what are the level of priority of people in the waiting line, in the waiting list to get a cardiology appointment. And so you can see that on the left, you have for priority, which is the first or kind of yellow color, we have 12 people, and you have 70 days of waiting on average. For normal priority, you have 186 people on waiting and 122 days. On the other hospital, you have a very urgent case of one person that will have 20 days of waiting, and you have 26 days for priority and 23 days for normal priority. So first two important things for the for our discussion of the data availability and this idea of data being made available to citizens for use. First, this is useful information, of course, but also is data that is not on real time. This data refers to the period of between November 2020 to January 2021. So we are in May, basically June, and we had kind of 5 months already since the last data was published. And so this gives the patients the possibility to know the waiting times for them to make a choice, but it has a lag of 5 months. And so the current situation they will face when choosing a hospital may no longer be the one that was 5 months ago. Sorry. And so the issue of what is the time of data, what is the lag in the data that we should have on these things, on this information, is also an important element. And so I think it's another element to discuss when we talk about making data available for decisions by citizens. Because 5 months is kind of a long time. And of course, if people are waiting 122 days, those that were in waiting 100 days ago are no longer waiting at this point, which means that for sure, this data currently is different from what was at the time. And so if patients are deciding based on this data, they will be deciding based on outdated data. But if you think about what would be ideal, and you could say, oh, we should have the system providing data on real time. Why cannot the system provide data on real time? Well, not sure that it on real time is going to be useful as well. If I knew who was waiting this week or today, that probably was not as much as useful as knowing what was the average waiting time in the last months. Because day-to-day fluctuations or week-to-week fluctuations in these things may not be representative of what as I, a patient, will face. And so this idea of collecting all the data in real time, in this case, is not user data, but it will be kind of high frequency data, may not be the most useful one for taking these decisions. And so even in this small idea of deciding, patients deciding on the basis of data made available by administrative bodies, we need to think not only how it is made available, but what was the frequency on which should it be made available? What is the type of aggregation that we should have on this data? Sorry. And I don't have any definite answer on this, but I'd like to hear your thoughts as well on this part. If someone wants to provide data for others to decide, what is the optimal frequency of those data? What is the optimal aggregation over time of this data? But this just sets the scene and shows that if, now going back to the patient side, as a patient, I may want to wait to go to the hospital that has a lower waiting time than the one that has higher waiting time. And so I can choose slightly different ways if I have the data than if I don't have. This initiative, this policy initiative, was created and the government announced that it could bring several benefits to different stakeholders. So it had for patients, they will be able to choose where to go. It will increase the patient's trust in the National Health Service. It will also be helpful in providing general value, people making value of the NHS institutions. To the GPs, general practitioners, they will have a different role now. They could be more active on having information and providing information to patients and helping patients to decide. It will improve the relationships of GPs with patients in hospitals. It will increase hospital efficiency. It will improve loyalty of patients through excellence in hospitals by having lower waiting times. And the whole idea for the NHS is that this will actually bring down waiting times because hospitals would like to cater for the patients. And so then here, we're starting having a second point of interest, or at least an interest for me as a health economist, that was to think, how is going to be the change in decisions by the hospitals, since they are being targeted by this measure. So we should have patients deciding where to go. And so that should change how hospitals work. And then I want to think about, okay, if we think that hospitals are going to react to this, what kind of data should we look for to try to understand their reactions? And then I go to what data do we actually have to measure that. And so my next step on this digression through this policy measure was to try to understand what's going on in terms of reactions. How do hospitals change the way they work to respond to this possibility of patient choice? And then I had at the time a curious document, internal document of a large hospital in Portugal. So the law was adopted in 2016. So this is a document that goes back to 2016 that expressed the view of how the hospital expected things to change. And the first element is that they expected referrals of hospitals to be more linked to geographic proximity than to waiting times. So they thought that patients, although they can decide based on waiting times, and we saw that some data will be available for that, that patients will decide basically based on geographical proximity. They want to go to the closest hospital. The second thing that they reflected on was internally as the hospital. They said, as a hospital, we cannot increase the supply of consultations. We cannot increase the number of patients that we see without reducing other areas of activity. And they said that the additional number of appointments do not carry more revenues. Since this is a National Health Service hospital, they receive a global budget that does not change if they receive more patients. And they discussed the adjustment possibilities that they could have. Okay, do we react? They could reduce time duration of appointments. And so they can reduce also the turnover time between patients. They could reduce the number of follow-up appointments. They could ask, have a talk with GPs and ask GPs to send patients according to certain rules and to take them to other places. Or they could also propose the government that they should receive some financial reward for taking in the patients. And if they are taking patients that are not in their catchment area, they should receive some payment from the original catchment area hospitals. So you see there are several types of reactions that are possible, and each of them will have a different different implication in terms of the data that I will need if I want to address this question. So if I was thinking about how to get data to know what's going on here, what happened here, I will need to collect data from the hospital, but on different levels. I will need to know very detailed information on duration of appointments to check whether they actually change the time duration of appointments. But I also need data on scheduling, whether they schedule more or less follow-up appointments. And I will need then more soft data in the sense, did they had meetings with GPs in the area so that they will try to get a different relationship with GPs and change referrals so that they only get the appropriate patients. And so here, when trying to link to the initial introduction, here you're going to need information that is collected with relatively high frequency, the time duration of appointments and follow-up appointments. That will be administrative data. But if you want to know how do they change the relationship with GPs, that is not going to be recorded anywhere. And that probably will need some surveys to know what the hospital has done on that part and actually serving some GPs to understand what's going on. So you can see that even for a very restricted policy measure, like this patient choice initiative, we have demands on data and we have needs in terms of data that is not just administrative data of what happened. We may need to understand fully the problem. We may need to have different sources of data and different ways of collecting the relevant data. Now, I'm going to concentrate now in the conceptual framework for a couple of minutes, because I want to highlight why do we need this conceptual framework to then use the data in the proper way. So just having data does not give you the full answer. You need to know how to interpret the data. And most importantly, we need to know how to organize the data to understand what is the reality that we have at hand. So the starting point of this conceptual framework is that the broad view about the policy was that competition is beneficial. And this is a kind of very general statement that many people consider to be there, that we should have more competition. When we apply it to healthcare, we need to be careful because we know that the healthcare markets have many imperfections. And so we need to be more careful about the effects of introducing competition. And in particular, if we introduce competition as a tool, as a policy instrument, that was the case here. So in a sense, by having this choice setting, we would have a competition between hospitals trying to attract the patients. Now, on the conceptual framework, this basically frames the issue that we have with this patient choice initiative as an issue of quality choice with regulated prices, and this was taken a bit on a previous paper by Luigi Siciliani and Oddhuda Strom in 2019, and they said that from a social welfare point of view, so for the welfare effects, so the benefits to society, that will be having ambiguous results. So I'm not going to go on details on it. I developed my own framework to address this issue, and I have a couple of changes to the Siciliani-Strom paper. But here the basic point that I'm going to highlight is the following. In this case, since we are talking about the National Health Service, if a hospital has more demand because it has a lower waiting times, that is not going to bring more revenues, which means that we need to understand how the provider, the hospital, will change its decisions, in particular, how we'll try to cope with more demand that will increase the waiting times of that hospital. And so I needed to kind of understand what is the hospital doing, how do they work, and so there was a kind of bit of detective work trying to understand how do they value waiting time as a decision maker. And there it's curious because then we can see that in many hospitals and around the world, you have waiting time as a KPI, a key performance indicator in management's assessment. And so they don't want to have very long waiting times, but having very low waiting times is also a problem because they need to put more resources in getting low waiting times. So the question is, how do they get a balance? So it's not clear that they just want to have the lowest waiting time ever, but they don't want also to have the highest waiting time ever. So they need something in the middle. And so I had to kind of model that, and I did put a simple function to think about it that I will show very briefly in a moment. Now, this created the need then for me to kind of develop a model to guide the empirical analysis that would reflect these differences. So the possibility of patients choosing, but also of the hospitals reacting and waiting time choices that they will be making. And so I'm not going to go into the details of the models. This is just to show that I have did a model. Okay, so I'll be glad to send the slides. Well, the slides are with the organization. So those of you that are more interested in knowing the details of the framework, I'll be glad to explain later or by email, discussing over a different Zoom talk if you want. That's no problem with it. For the point here, I'm just saying that I want to reflect the sort of elements that will be here. I need to, in this framework, I need to think about patient benefits. I need to think about managing waiting times. I need to think about the choices that the hospitals make in management that gives origin to different waiting times. I need to think that patients choose based on geographic proximity, like it was said in the law, but also things like waiting time that works with an implicit price. So this will give origin to different situations. I'm not going to detail what's in here. It's just a condition that helps to have very complicated expressions that nobody follows up. I'm not even sure that if I was seeing this for the first time, I totally understand it. But here, the point is how to interpret when we do these conceptual frameworks. And so I transform this into a single picture. And the critical element that I'm going to use here is that as a starting point, I have hospitals with different waiting times. If they have different waiting times before the patient choice possibilities, I need to account for that asymmetry. And once I consider the asymmetry in the hospitals at the starting point, which can be due because they have different costs or because they have a different way of managing the waiting times, then I have to consider that that asymmetry in the beginning will carry through to the way they react to the policy choice. And so that's what I want to highlight in the next picture here, which shows that based on those equations that I was able to derive, I was able to set up this picture with just putting some numbers to the equations and showing the following. We may have hospitals that are good in managing waiting times, and so they are what I call the top hospitals. Then I have the ones that are bad in managing waiting times, and they are the bottom hospitals. And when we have this patient choice, we would expect that patients of the hospitals with longer waiting times will go to hospitals with less waiting times, with lower waiting times. And so we have to think how are going those hospitals to react. And then what I have here is what I highlighted with this picture is that the hospitals will react differently. The hospitals that have low waiting times to start with, the top waiting hospitals, they will be having a kind of a threshold in terms of the relevant elements of cost in this case, where if they have a very high level of this critical cost C that I put there, they will increase waiting time in that hospital. Otherwise, they will be still be more efficient and reduce the waiting time here if they are very efficient. So in the lower end. Now we can have a situation where both hospitals react the same way, meaning increase in waiting times in both hospitals. We can have a situation when we have reduction in waiting times in both hospitals. And you have a situation in the middle where you have some hospitals improving situation, becoming more efficient in a sense, or more quality in a sense, which are the bottom hospitals because they lose patients to the other hospitals. And you have an increase in the waiting time of the ones that were the best hospitals because they are receiving more demand. And so this creates first, this has two implications that are important. First, above all, I do not have a single possibility of reaction. So saying that I am going to improve the situation of waiting times in the hospitals because I have a patient choice initiative is not true. I can have actually a worsening in waiting times. And so that makes relevant to make the assessment of the policy. But also important is that the different hospitals will react differently, which means that when I go to the data, I will need to make a differentiation between the hospitals that may be net receivers because they are in the top part of low waiting times and the other hospitals. So I cannot just take the data that exists on hospitals and make a regression analysis. I'll make pictures of those hospitals because then I'll be bundling all of them together. Since the conceptual framework tells me that I should expect different reactions from different hospitals, I will need to, in the data analysis, to separate the two groups. I need to create the two groups, which ones I will be calling the top hospitals and the ones that will be the bottom hospitals, the more efficient and the less efficient. And so the use of data cannot just be collecting the data and using whatever is available. It needs to be guided by some sort of conceptual framework that could have said I could just treat all of them equally, or in this case, it's telling me because they were asymmetric in the beginning, they will react asymmetrically. So I need to consider that they will have to be two groups, two different sorts of reactions. And that is what the important part of having this conceptual framework defined first. How am I going to use the data needs to be guided by some principles, and I need to actually think about how I can first introduce the motives by which I have the asymmetric responses. And so this means that we have to use methodological options that use available data in a way that is coherent with the expected framework for effects. And so data availability is necessary, but we also need to have a way to think about the data. We need to join our concepts, our methodological way of seeing what is the expected result, to join now with the methodological treatment of the data to get an answer to the question of what was the effect of the policy. Okay, so Also, this framework highlighted that I could also expect different effects on quantity, that will be here, the number of patients that go to each place, and on the quality, that will be the waiting times. Which means that in the empirical validation, in empirical analysis of the policy, I will need data on different elements. And so just having one will not give me the full picture. And so this will create the need to address both quantity and quality and look at looking on different data for each of these two options, these two variables. Here we could discuss other policy options that could be used. I'm going to skip that part. What are then the testable hypotheses that we have for the data? What can we extract from this discussion to look on the data? First, change in quality, which is waiting time here, is different in low waiting time and high waiting time hospitals. I will need to split the sample. I will tell you how I did it. I need also to think about change in quantity, which is the number of appointments, where I will expect a redirection to lower waiting time units that will be guided by the lagged information on performance, which I showed you is publicly available. And also another implication is that if I have hospitals that will be attracting patients from other areas, then the geographic dispersion of patients going to low waiting time hospitals should be different than the geographic dispersion of hospitals that keep only the patients they had before opening the choice of patients. Because the other hospitals that have high waiting times, they will be losing patients, so the geographic dispersion they have is not going to increase because they are not receiving patients from other areas. And so the framework that I put forward gives me these testable implications, and I'm going to go through them now. Now let's bring in the data, and the information I had to work with this was actually only public reporting by the government, which is available on the web. And so if the questions you want to see the real data, if I clicked on this link, the blue link, I take you to the website where the government has the data. I have data per hospital on specialist appointments and on the percentage of appointments done within the maximum response time. Now, in terms of data availability for a researcher, I would love to have data per patient, how much each patient waited, how much, when did he took the decision to go to a hospital, and what are the characteristics of the patient and the characteristics of the GP that decided with him. I don't have that data. I only have the percentage of appointments done within the target time. So I have only a very imperfect proxy for this. I also have information on the DRG episodes. When people go to a hospital in Portugal, they are classified on diagnosis-related groups classification, so a patient classification system, and I also have the geographic origin of the patients. And so I can work with this somehow. Now, I'm going to, as usual, how it is very usual when researchers have to use data, I'm going to make some assumptions that relate the data that is available to work with what I want to measure. And this is a problem that everyone that works with data faces at some point in their own professional life. The data that we want to have is not the data that is available. And the data that is available is related somewhat to what we want to measure, but we need to understand what are the assumptions that we need to make that relationship. In this case, I have the situation where I have only the percentage of appointments done within the target time. So I have to assume that a higher percentage of within target waiting times has a positive association with lower waiting times, which is the relation that I want to look at. And so that will be my basic assumption coming from my conceptual framework and matching the data that is available. And then I will have the hospital admissions pattern that I will assume that reflects the specialist appointments through geographic pattern. So I have consultations that may result in admissions. So I don't have the direct information on all the consultations by patient. Although hospital admissions for the geographical dispersion part, I will have individual data here. But I have no aggregate, but I don't have such individual data on the aggregate number of consultations. So the first definition the first step I had to do was to define what was top performance hospitals and low performance hospitals. And then I do a regression analysis. Of course, here probably those that are the students in statistics or that do policy analysis, they will think, okay, great, let's do a difference in difference analysis. Okay, sorry people to disappoint you. It's not possible here as I do not have a control group. The policy change applies to all NHS hospitals. So yes, I would love to do a difference in difference, but I cannot. And what I can do the best is to detect whether there is a... I can just try to detect whether there is a broad consistency between data and theory predictions. So what I did have to decide first was to create the top and bottom groups. I created the top units by using the data before the policy change and saying all the hospitals that were having waiting times that lead to patients within target times above the median value in all the months before the adoption of the policy will be the top performers. If it was enough, if a hospital during a month had a percentage of patients within target times that is below the median value, it will be classified as a low performer. We can have a sensitivity analysis to this definition, but I needed to have something to work with. So I need to take a decision as a researcher, which will be the right way to use the information to create these groups. So that was my approach, and we can discuss further what other options will be available. Also, I need to tell you what was the data that I have available. It's monthly data, and I have actually data from January 2013 to February 2020. Currently, probably I have already March as provisional data, and this is available on the website. And with this data, I need to think about how to play with it. I can build a time trend, which I did, that allows for a different change in slope. So before-after analysis for the patient choice initiative. I will have a dummy variable for the change. I can have the percentage of patients that are within the target time for surgery with 1 month lag and 3 months lag. I have a percentage of patients with target time for appointments with 1 month lag. And I'm going to use fixed effects at the hospital level to perform the analysis. So recapping what I'm doing, quality is waiting times, proxy is a proportion of first visits to the hospital. So it's very aggregated data. It will be great to have individual data. I think it should be improved with, results could be improved with that. I have the number of patients that have a first appointments in the hospital per month. So I have a measure of demand, and I have the problem, a methodological problem, that is the monthly data on waiting times will have a high persistent. So they will be a high persistent data. So it's not just a matter of frequency, is that they don't vary that much from month to month. And so that will create me some problems that are not totally solved in terms of extracting clean results from the data. So what I did was just now a linear regression models where we have the standard situation of having a trend, a change in the trend after the policy change. I throw in fixed effects at the hospital level, monthly effects for taking into account seasonality according to the months. I actually, in the end, also removed the 2 first months of 2020 to get a more balanced panel in terms of the months the months that are included. And so I just run the typical regression for a before and after analysis. So what is the variable of interest is this trend change that would be associated with the policy change. What happened after the policy change? And what we have from there is actually a very kind of disappointing results on my side, and I'll try to explain why I think that they don't still tell the full picture and why it's still working in progress. So if you look on this, from 6 alternatives of analysis, I have no effect found for most of the cases. So what's going on behind this? What is the problem that I have to face in solving this problem? First of all, the more interesting result that I want to look for actually worked well. And the more interesting result for me was to know how do the hospitals that have lower waiting times, and so that will be attracting patients, are going to react to the policy change. What's going to happen to them? And what I have with them is that they have this negative coefficient, which brings in the issue of having a lower number of patients, a lower proportion of patients that I have a consultation within the target time. And so if they have a lower number of patients within the target times, it must be the case that waiting times have increased. And so we have a negative effect on waiting times coming from this policy change, because these hospitals have to cope with more patients. Now, curiously, those have to cope with more patients have a negative effect, but the ones that free up the patients to go to the other hospitals don't benefit from it. So I should have seen here something in the bottom hospitals, something that will be an increase in the proportion of patients treated within the target time. But that doesn't show up. The signal of the sign of the effect goes in the right direction. So it's a good signal that it goes in the right direction, but doesn't mean anything. It's too random for that. Now, another important part here is how confident can I be on these results? And actually not much, because now it comes for the statistical part. Since I have high persistence in the data, I just computed the standard, the usual standard errors, which is this first T. Then I computed the robust standard errors, the ones that account for the possibility of existing autocorrelation and heteroscedasticity, and it brings a much lower value. And then actually, then I just decide to check for autocorrelation in the data and to check also for the introduction of the lag-dependent variable and the existence of a unit root in the series. And all of that is true. So if I introduce a lag-dependent variable, everything becomes non-significant on here. And so this creates a question for which I don't yet have a good answer. That is, I have monthly data, and with monthly data, the proportion of patients that are treated within target time varies very little from month to month. So I have a correlation between each 2 consecutive months that is very, very high. So
sorry, Professor, 5 more minutes, please. Yes.
Okay, thank you, Nook.
Yeah.
So I tried to work with that in several ways. One of them was just to use month to month, so December over December, and doing it every month, and still don't have any effect found. So I have a problem that is related to the frequency and nature of the data itself to try to extract any conclusion. When I look on the quantity part, on the first appointments, then I have less of that autocorrelation issue, I have less of that inertia issue. And with a lag-dependent variable, and I actually have what I would expect in the top hospitals and not so much in the bottom hospitals. And if I put information that patients should be using, I don't really get what I was expecting to have in some of the times. And so I have an issue that patients may be using information, but may not be using in the way that we thought, or maybe they are not using the information after all. So the next situation was to look on the dispersion in geographic dispersion of patients. And for that, I have these pictures that, well, let me show the other picture now. This one that shows that the dispersion of patients have actually increased. So I have here in the horizontal axis an indicator of how concentrated is the origin of patients. And if it is higher, it's more concentrated. And so what I will expect is that top units will face a reduction in concentration, which actually seems to be happening in 2018 mainly. 2019 data here are just provisional. I just have 3 months that are preliminary data coming from the hospital admission episodes. And so, but I still have some information on the top units that is consistent with this patient choice initiative and basically not much of a change in the non-top units. So it seems broadly coherent with what we have. So recapping to what I'm intending to do here, I started this discussion with a new policy with more freedom of choice of hospitals. And then I said, okay, if we want to bring this to the data, how can we use the available data? And I was thinking, okay, let's have a theoretical framework. And with that theoretical framework, I could devise an empirical strategy that is coherent with the framework. But that created two methodological challenges that I'm still trying to find the best way around. First is how to define the asymmetry between players, between hospitals, knowing that I don't have a clear administrative definition for that. I have an option that was also using, besides the median, 60% of the median in the main variable, and it gives basically the same results. And I have the problem of autocorrelation in monthly data, and makes it difficult to detect any effect. So the data issues is not a matter of just asking what data is available, it's also understanding how it's the best way to use the data, knowing that sometimes the frequency of the data is actually a very important element in the type of analysis that you can do. And of course, as a researcher, I will always claim for more data, but I think it's also important to think about how can we use better the data that is already routinely available, what things are collected available. So in this case, I could have more things to do, and I could try to look on more aspects related to this competition in healthcare. But probably I'll stop here and saying that if I wanted to choose the data that I would like to have, probably having individual level data would be great. But even without that, we think we can do we can have some ideas. The other important element to conclude is that if we want to talk about the shared decision-making process, we need also know to know more about information that is not collected in a routine way. And how do patients decide with physicians is information that is soft information, let's say, and it's not easy to think that we're going to have it collected in a routine way. And so trying to understand these better poses the challenges also on the type of data that we should collect. And of course, as a final remark, what can I say about the policy? I'm not sure that we are making a wise choice in making patients deciding without putting some money following patients to the hospitals. But even before we can reach that conclusion, we'll have to look more on data, look for other different types of data to complement the view, and have a full policy analysis of this element. And I think with this, I'm concluding the presentation. Thank you for listening to me, and I'm open to the questions. Thank you, Nook. The micro is yours again.
Okay, thank you very much, Professor. It is a fascinating topic with a crystal clear explanation from you. You have highlighted that data is important. Data is a new gold nowadays, they say. So I'm sure that the audience has more questions in their mind related to your presentation. I already seen some question in the chat box. Again, if the audience wants to add more question, you are pleased to add in the chat box. But before we continue to the discussion session, we would like to ask all of the audience to join us for the photo session, while Professor Barros maybe grab some drinks, and we can continue to the discussion. But of course, we would like to have a photo session with you also. The picture will be uploaded to Polytechnic Statistica STIS official page on Instagram, Facebook, website, and ICDSOS publication. So I would like to ask the documentation section to take charge. Please, Sayla and the team. Sayla. Ibu Ika Yuni, is there a document section that could take in charge for the
yes, Bu Nuke, but please host unmute the Sayla, please. She can unmute herself. Thank you.
Okay, ladies and gentlemen, please allow me to lead the photo session. To participants who didn't have any connection problem, please turn your camera on. Okay. Let's start with the first slide. 1, 2, 3. Once again, 1, 2, 3. Okay, the second slide. 1, 2, 3. Once again, 1, 2, 3. For the third slide, 1, 2, 3. Once again, 1, 2, 3. The next slide, 1, 2, 3. Again, 1, 2, 3. Okay. For the last slide, 1, 2, 3. Once again, 1, 2, 3. Okay. The photo session is finished. Thank you to all of the participants.
Thank you, Seila, for taking charge for the document section. Very well, ladies and gentlemen. Now we come to the question and answer session. There will be 2 sessions, and each session is from 2 or 3 audience, maximum like 2 questions each. And the event section team has summarized the question from the chat box. So I will start the share screen here. For the first question. Have you seen my share screen?
Yes, we can see that.
Okay. I think sorry, yeah. So for the first question is from Lutfi. She sent the question using my WhatsApp chat box because cannot write in the Zoom chat box. So regarding the model, in the model, it seems that all hospitals provide the same level of treatment. Like in the slide when you share the screenshot from the information hospital that show how many days for the waiting times. So is it so, or it is assumed to have the same? Because I think some hospital have the different kind of specialty. And do you consider the possibility that some hospital might provide certain level of services that creates asymmetric situation for the patient? And then the second question from Lutfi is that, do you think that the patient changed in the middle of the process? Like he already wait in the one waiting line session in one hospital, and then in the middle he can change into the other hospital. Does it will give effect on the demand side? I mean, in the hospital new destination demand. This is from the first audience, the question from the first audience. And then I think I would like to invite Mr. Pribadi Widyatmojo that already write his question on the chat box to ask directly to Professor Barros here. Hello? Mr. Pribadi, can you hear me?
Yeah, I'm very sorry. Yeah.
Please.
I have 2 questions. And the first I have write down on the chat. And the second I just write down in the chat either. I'm interested in your explanation that after you told me about the result of the analysis, you told me that you you told me we have to check again our model. Should we can we change our regression model in order to fulfill the data assumption with the available data? Thank you, Mr. Barros.
Okay, maybe I will show the first and second question from Mr. Pribadi that already share in the here in the chat box, Professor. So if you please answer the first question, this first question, and then the second question from a different audience. Please, Professor.
Okay. First of all, thanks for your questions. So I will try to answer the ones that are on the screen by the order that Nook is putting here and try to get all of them. First of all, in the model, yes, I assume that they provide equivalent treatments in terms of quality. In this case, I'm looking on consultations. So the only thing that I need to say is that consultation of cardiology or dermatology or so on is done by doctors that are equally qualified, which is a reasonable assumption because all of them have to be certified by the Portuguese Medical Association to be working, and they were selected by hospitals to be hired. And so for the consultation part, they will have slightly different qualities, but they should be the treatment. Now, the quality measure that I was using, which is the waiting time, can be different from hospital to hospital, and that's the variable of interest that I want to focus. And the waiting time itself is influenced by the practice of the physicians, sure, but also by the organization options that are taken. The way the hospital managers help scheduling visits, the way that services inside the hospitals organize themselves in terms of activity in the wards, in the consultations, and in the emergency room. All of that will influence the waiting times. And so in terms of providing the level of service, in terms of this waiting time, they will be different. And that's precisely my point here. They start with hospitals that are different in the beginning. And the question is, what happens to their asymmetries once you have the policy choice? When you have this change in the possibility of patients choosing, what will happen to these waiting times? Part as mechanic effects of patients going to a place, but also part as the way their services will reorganize themselves in response to the policy. Second, do you think that the patient change in the middle of the process gives no effect on the demand side? Well, once they are already into the process of having an appointment before, they will not change to a new hospital. They have to wait until the end of the time. Now, it's I didn't detail here all the policy, but the target times that the hospitals have a level of priority, and they have patients will should wait at most 120 days. After that period, they can choose where to go again. And so in a sense, if someone is caught in the middle of the change, so if they are in the waiting list for seeing a doctor when the policy was enacted, if they were close to the end of the 120 days, they could after that period and choose a different hospital. And also, of course, after 3-4 months, all the patients will be in the new process anyway. Here, the most important part is whether the patients that are in the middle of the process actually have information that they can choose the hospital. It's because if they are not seeing the GP, they may not be aware of this new possibility. And part of the policy change comes through general practitioners informing the patients that they can that they can choose the hospital of their liking according to this information. I didn't have the detail in the presentation about it, but the curious element on the information that patients may have to make these changes was the one that I showed you, but also the GP will have information in its own computer about the health system in the National Health Service. And so it's not clear that the information that the GP will be seeing in his computer when he's in a consultation with the patient to decide where the patient will go is actually the same information that the patient has seen on the website, which actually creates an interesting issue for data usage. That is, if you want to have two different actors, the general practitioner and the patient, to decide jointly on something, they should have the same information at the same time, and it's not clear that's happening, which actually creates an interesting issue about how do they make this decision process. And for that, we don't have statistics to look on that part. And probably only by surveys we could eventually get that information. And that will affect also the answer to this question. What do the patients know? When do they know it? So that can change in the middle of the process. Okay, sorry, it was a long answer for a short question, but I hope it clarified the part. So we can move to the next ones. What should I use approach to this problem? Should I change the qualitative research? Okay. In the first part, on having the framework, I was not using real data. I was just using the model and that framework that needed to be somewhat elaborated, just to highlight that our first intuition about effects actually needs to be perfected, needs to be improved with some careful analysis that may require models in some cases. In this case, it required a model because the asymmetries that we saw in the beginning, when translated into a simple framework, will actually mean different reactions, and or the possibility of different reactions. And that, of course, is just qualitative in nature, but tells you, informs you about the empirical strategy. The empirical strategy needs to allow for differentiation of units. And so in that sense, what I wanted to extract from the qualitative research of the conceptual framework was that I need to split the sample in some way so that I know that I have capturing not the average reaction of two different groups, but actually the reactions of each of the groups. And of course, identifying the groups is an issue. And that is still one issue that that may appear in other situations. But here in this case, I decided this way. There are other options on which I can do. So I was using the part with no data to inform me about how I should look at the data, what things I need to do to get the most out of the data that I want.
Yeah.
On the regression model, yes, we could use different regression models, and I actually have been using several regression models that in the time available, I was not able to go through all of them, but I had different types of model using there, some more elaborated, others less elaborated. I could even use the models that would say, although here I presented a split that I created between top and bottom, I could say that I would have latent classes of hospitals, and I could try to use a latent class model to try to identify endogenously how the groups will be formed. But then I will need also something that will make me assignment the two.
Yeah, thank you very
use
much.
Different models to try to cope with the same qualitative research question. And actually, we should do it often to do that. An issue that I'm facing here in using different regression models in this context was with the monthly frequency of data that does not change that much for each month, like the proportion of people that are treated within the target time, more sophisticated models will not actually identify much of it, because basically those models require variation that does not really exist in this data. And so what I tried to do was to use year-on-year situation. So December of one year against December of the previous year. But that, of course, loses a lot of data in the middle. So it's also a cost of doing that. Of course, I can do that for every month and see whether the results are consistent. But then I have a reduction in the sample size, which also affects the way that I can use more sophisticated models, let's say. But yes, you're totally right in saying that we should try to use different regression models to see whether they tell you a coherent picture of the situation.
Thank you, Mr. Barros.
Okay, thank you, Professor, for the explanation. I think and I hope it's already answered the question from Lutfi and Mr. Pribadi Widyatmojo. Thank you very much. So we can go on to the next round. I have already here from the chat also from Bapak Ibnu. So the question is that the geographical areas might be translated into additional costs for patients. So do you think it is possible to accommodate this? Because in the beginning, you have already mentioned that there is no monetary price to the patient, but somehow I'm still thinking that these additional costs can be treated as payment per case that you mentioned for the future research in the later slides. And then the second coming from Ibu Nori. The question is from the theoretical framework, different hospitals need different treatment. The first statement that you, when you build the theoretical framework. So it is important to differentiate the hospital quality, and is there any other differentiation criteria to classify the hospitals? How model accommodate the moderate quality of a hospital, not only by a top or low tier, but also to catch the moderate variation in it. And for the third one, I think I already see from the chat that Mr. Ari Wahyu already write some question. Maybe you can ask directly, Mr. Ari, please. While I'm copy your question into the slide. Thank you.
Okay, thank you, Ibu Nuka. First of all, Professor Baros, thank you very much for your today. I think it's very interesting talk for us. And I have two questions actually, and will be grateful if you can explain a bit more about this. So the first one is like how the situation of the pandemic. I think we have been many pandemics in the world, and now we have COVID-19 as well, right? And how this pandemic will influence the health system model that you have explained. I'm not really sure if you already taken into account this kind of pandemic as well in your model, but yeah, I'm wondering about the resilience of the health system during this pandemic, maybe. And the second one, I think the second one quite similar with the question from the previous audience, I think. You already mentioned that the referral system by the general practitioner, it seems to link more to the geographical proximity, right, than to the waiting times. And are there any constraint consideration, such as some particular patients maybe require specific medical devices, or it was assumed that all hospitals have the same medical devices sufficiency? I don't know the situation in Portugal, but in Indonesia, the difference is very huge. Some hospital is very modern and sophisticated, but some are more traditional. Okay, I think that's two questions. Thank you very much.
Thank you, Mr. Ari, for your question. I will share the my screen again, Professor. Start from the first, second, and third. The last one from Mr. Ari.
Okay. First of all, thank you very much for the questions. Let's start with these last two ones because they are quite general and they actually go well beyond what I presented here. But I think I can have I can add some elements to it. First of all, how does the COVID-19 changes the model that I presented? Well, in conceptual terms, does not change that much in the sense that what I was looking for was how do hospitals and patients interact on this setting. And what we have seen with COVID-19 is that patients will still want to be treated at some point. I'll come back to a second. But from the hospital side, at least in Portugal, they created separate circuits for COVID-19 patients and for non-COVID-19 patients. So they have a higher cost of seeing the patients, but they are still seeing some of them. So it changes somewhat, but does not change dramatically in the sense that the implications that different hospitals will react eventually in different directions. It's still true, and that if I wanted to do the analysis of their reactions to policy choice, I probably should take into account their differences. That's one part. Now, the more interesting part is how much the decision process of patients actually changes with the COVID-19, and that changes, and that changed a lot. It was not on this data, but it was coming from another source. We, as almost everywhere, I probably have done that in Indonesia as well. We have carried out several surveys during COVID-19 period to understand what was happening. In one of those surveys that we have done in our research center, we looked on whether people in the first 3 months of the pandemic had cancellation of appointments with doctors. And we asked whether the cancellation was by decision of the patient or the cancellation was by decision of the healthcare provider. And we got the information, and what we got from there, it was a representative sample of Portuguese people above 18. It was 1,000 individuals that were surveyed, and we have a population of 10 million. So it has some margin of error, of course. But we got that 20% of the patients said that they canceled a visit from their own initiative. And that makes, and it was roughly more or less the same thing for the hospitals. The hospitals also canceled appointments. So what we have during the pandemic is that both providers of care and both patients decided to have a lower number of interactions. So they canceled appointments they had. And so in a sense, if I wanted to go back to the model and introduce COVID-19 on that, I would have to add the fear of getting COVID-19 as a reason for patients not to look for care. And I think that's something that has been a concern. And in particular in Portugal is a concern about cancer treatments, about oncology, because in some types of cancer, during the last year, they got less, kind of 40 to 50% less new cases that they have done in the previous year. And the biology of cancer didn't change with the pandemic. So it must be only cases that are not being detected. That has been a concern about this change in decisions of people of not seeing the doctor because they are afraid of the COVID-19. So the decision-making of patients seems to have changed in ways that we need to account in the models if you want to be more accurate in the interpretation of the data that we observe. So that's one part of the answer. The second question is about the resilience of health systems. Well, the resilience of health systems is a fascinating topic. And let me just make some own advertising. In that expert panel of the European Commission that I work with, we had issued recently an opinion on resilience of health systems. And there was a shorter paper published recently detailing what could be how should we look on the resilience of health systems. And there are several works on the resilience of health systems. Basically, resilience here, it's a concept that should force us to think about 4 elements. Should be about the ability of the health system to identify an unexpected and strong shock. So it's not anticipating, because if it is anticipated, it's not really an expected shock. If it is anticipated, it becomes expected. So it's to identify that a shock that was not anticipated is taking place. So it was able to understand better, say in January, February last year, what will be the pandemic. The second aspect of the resilience is to absorb the shock. How can the immediate impact of the shock be included into the system? How can we react to that? And we see that with the changes in the COVID-19 patients' circulation, the adoption of protective equipment by health professionals, all the care, all the issues that are around how the system, so the huge demand for ventilators and for new ways of treating people, all of that was the absorbing of the shock. The third element is to learn from the shock. How can we do better? And here we are still learning, but we have early lessons as well. A quick example from the Portuguese resilience part on the pandemic. We saw first the COVID-19 hitting first Italy and Spain in Europe. And so after seeing that, Portugal knew that it was coming. And so they decided in the National Health Service, jointly with the Portuguese Medical Association, to announce a strategy that was a strategy of 80%, 50%, 5%. It was meant that, and it was done before any patient arrived in Portugal yet. That means that 80% of patients should be followed in primary care, 15% of patients will need to be in hospital care, and of which 5% will be in intensive care units. And so the numbers were actually different, but they tried to learn from what was happening in Spain and Italy to try to understand how they need to organize the system. And so they had a huge number of people that will not need hospital care, and they should not go to the hospital to avoid crowding the hospital. And that was one of the mistakes, early mistakes in Spain and Italy, that everyone feeling bad about the pandemic, but feeling bad and feeling that they were having COVID-19, went to the hospital and just crowded them out. So that was one way of learning. The first element of the resilience is to change the system to a new normal, what is becoming a new normal. And that's more difficult to do and it will take longer. And I think that we'll still see that taking place. Now, that means that much of the resilience of a health system is not so much on having stockpiling of whatever, but it was having about ability to decide quickly and to mobilize resources once you identify what is needed. So it's a kind of prepare to being prepared. So you cannot prepare for all possible shocks that you don't know what will be. And that means that you need to be able to prepare to take quick decisions, to change the system if needed, and to mobilize resources if needed to answer the unexpected situation. Again, an example from Portugal, which is a reality that I know better. The roles of but probably this one is probably very general. The roles of medical doctors in hospitals change. At some point, you had doctors from other specialties than infectious diseases actually helping with COVID-19, because you needed to have everyone joining the effort. So we had hospitals that closed substantial parts of orthopedics and have people, specialists on orthopedics, actually helping on the wards that had COVID-19 patients. We had to redeploy nurses that were in different services, say dermatology, to actually learn how to use ventilators to help with the patients that needed ventilation, mechanical ventilation. And so they need to redeploy the resources. The ability to do that is part of the resilience of the system. So we should think about the resilience of the health system, not so much about physical resources, but about the ability to identify, absorb, learn, and change, and do that quickly as possible. As I said, I just refer for more details on the document. I'll be glad if you send me an email to send you a PDF of the work. I'll be glad to do that. Okay, and so that was the resilience part. Then we have here the question about referral systems. By general practitioners seems to link more to geographic proximity to the waiting times. Constraints in the referral system. The policy adopted takes out the geographical element as a mandatory element. So it should be still considered, but it's not the only thing that needs to be considered. And the waiting time consideration can overrule the proximity. So you could have patients traveling more. Now, it is true, as I mentioned in the other comment, that patients may face the transport cost of doing that. Yes, and probably that if we had individual data, we should include that information into the analysis. And it's certainly a relevant issue. It will be more relevant for certain patients and for others. Patients living in urban areas where you have several hospitals around, they will, before the policy, they still had to go for the hospital that was assigned to them. So the ones in the close vicinity of where they lived. But nowadays, they can choose one of the hospitals in the urban area. And so the travel cost for them may not be that large. And so for those, we should see that. That comment was actually much in line, and it's really spot on what was the early experience of one of the hospitals in one of the Portuguese cities of Porto, where they were complaining that they were being selected by patients in the city that were actually in the geographical catchment area of another hospital, but because they were the proximity was very high anyway, they decided to move to this other hospital. And for those, and one of the elements of those hospitals that was also mentioned in one of the comments was the reputation of the hospital as such. And not all hospitals will be able to do all the procedures, but many hospitals are able to do the consultations. It was the thing that changed with this policy. Now, if the patient expects that after the consultation with the specialist, the patient will receive an indication for surgery, then he may actually select the hospital based on the reputation for surgery. And since not all hospitals can carry all types of surgery, that may influence the selection process, the decision process. I actually see that a bit on the data, in the sense that the hospitals with a better performance in waiting times for surgery also condition a bit the demand for the choice of the hospital for the consultation. And the ones in the largest hospitals which have the ability to do whatever procedure actually attract more people and have higher waiting times because they attract more people. I consider that a bit included in the fixed effect at the hospital level, which I didn't show here the fixed effects, but the fixed effects show a demand effect associated with the larger hospitals, which are more differentiated hospitals. Even for consultations, some more niche specialties may only take place in certain hospitals and not all. So if the GP thinks that the patient needs to see a neurosurgeon before have a consultation with a neurosurgeon before proceeding, there are no neurosurgeons in all the hospitals. So they can only select some hospitals that will have that specialty. So in that sense, they will be constrained by the available offer of the hospital. And again, that is reflected in the geographical element to a certain extent and on the transport costs. So people living in the south of Portugal may have to come to Lisbon to see a neurosurgeon, and they will face the costs. Unfortunately, that information is not collected on routine data, and only with surveys on patients will be able to detect how much of those costs are present there. Again, on a different survey, we carried out an inquiry to people how much they spend in the last appointment they had in hospitals or in primary care. And probably because people go to the not so distant hospitals, the costs of transport are not very high. They tend to be less than 10% of the total cost of the visit, where the higher cost of doing a visit to a hospital specialist actually seems to be the drugs that are prescribed for the patient to buy after the visit. And so I take the point, I say it's a good point, thinking about the transport costs, and we should include them if we have survey data that can collect that data. But it's certainly something that not being available, we could consider that when you look on the geographical dispersion, somehow it captures a bit of that part. But yes, conceptually should be there as a monetary payment that patients may have to do. Another monetary element that could be considered would be if patients have a job that if they go to a consultation, they miss 1 day's wage. Sorry. So missing wage from work could be something that needs to be considered for some patients. But again, we need to have information from surveys on job positions. Oh, sorry. Okay. I think that I already covered a bit of this one as well.
Yes.
Yeah, I can use hospital quality on surgery, and that could be some indicators that are available. But the question is how those indicators will differ from the fixed effect at the hospital level. And that will be the problem here. Okay, next. Oh, sorry.
I think this also already recap in your previous answers.
Yes, I covered that one as well.
Okay, so this one also already, and I think all the question from Mr. Ari also already answered. Or is there any additional question about or something to confirm, Mr. Ari?
It's already crystal clear.
Okay.
Thank you very much.
Thank you. Oh, well, still on the resilience, if you are really interested in it, on the work that I mentioned, we also propose a test for resilience of health systems. So if at some point you want to test the resilience of a health system, we propose the way to do it so that we can learn more about the resilience element.
Yeah, Professor, we will be grateful if you can share that kind of research. Thank you.
Okay, we'll try to find it quickly. While we wait, we have more questions, Nick?
I think there are no questions. Wait.
Yes, so let me quickly.
No. I think there are.
Okay,
already.
I will. Okay, just getting a couple of seconds to go on the. Okay, already got the link. I'm going to put the link
On the chat
to everyone in the chat. Yes.
Okay.
On the resilience of our systems. Yeah, this is the kind of things that we could not do in presence. Having the computers around us allows to get to that.
Yeah.
So in that document, you have that I've just put the link. You have this idea of the resilience test and what means the resilience elements on this part. Now also, I see on the chat several questions. Let me browse whether I said. Oh, by the way, yes, the slides that I presented, I think they can be made available by the organization if they want. So it's okay with me.
Okay, thank you, Professor. We will attach your presentation together with the certificate of the event after this event finishes. So, because there are already all the question are questioned by the audience, and Professor Barros already give us a crystal clear explanation and answer all of the curiosity from the audience. So we have to wrap up until this point. I already have some recap from the today's discussion. I will read it aloud. First, the Portugal Patient Choice Initiative in 2016 is shared decision making that allow patients to have more option on hospital based on their preference. And the theoretical framework that presented here based on the fact that hospitals are asymmetric, then we should expect that the response are also asymmetric. In this case, the asymmetric is about the waiting time of patient to get treated. And then the highlight of the main results are hospital with a better performance in waiting time prior to the PCI have an increase in patient original dispersion and a negative evolution in waiting time for specialist appointment and weekly link between demand with past performance. Some potential future research in this field are available, such as working with the individual level data. I think Professor Barros already mentioned that many of the information should be gathered from the individual survey instead of the hospital information that already published in the web or something. And then involving a direct reaction to neighbor waiting time, and then also including the role of the general practitioner's payment and using normative analysis in the study. I think that's all the recap, ladies and gentlemen. Finally, we come to the end of the talk. I would like again to thanks to Professor Pedro Pita Barros for his informative and exciting discussion, and thanks to the audience for your active participation. Please give a big applause for all of us. You can have it applause online also.
Thank you.
Thank you, Professor. Hopefully, this discussion will be beneficial for everybody here. I represent the organizing committee for this pre-conference event of ICDSOS. Would like to apologize to Professor Barros and all of the audience here if some of you encounter any inconvenience during this event. Please don't forget to submit your paper or register as a non-presenting participant for our first international conference on data science and official statistics. And we will meet again, inshallah, in the webinar of ICDSOS on 13 and 14 November 2021. And for the feedback for this pre-conference event, as shown in the link, in the chat box, in the link in the chat box, the certificate is given only to participate who registered through the Eventbrite and fill out this feedback form. So if you want to claim the certificate, you have to fill the feedback as in the link. So thank you very much for your attention. Thank you very much, Professor Barros, and good afternoon.
Thank you, and congratulations to ICDSOS for the realization of this conference, and all the best for all the discussions that they're going to have. Thank you.
Thank you very much, sir. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you.